I am a hand surgeon. I've spent my professional career looking at, thinking about, figuring out, and operating on hands. Our hands really are pretty amazing. A lot of the more interesting things about hands don't make it into surgery textbooks, and those are the kinds of things that I'd like to run through with this presentation. Images of hands are everywhere. They're hard to draw, but drawings of hands go back to the beginnings of art. On the top left, images in the Cueva de las Manos in Argentina date back 9,000 years, and at the bottom, Michelangelo, Escher, Da Vinci, obsessed with depicting the hand. What draws people to draw hands? It might be because hands are so human. They represent the human experience. Instantly recognizable. Your hands are the part of your body that you see the most. Faces and hands are the only parts of some people that you ever see. Images of hands naturally catch your attention. Because they're so profoundly personal, it's very attention-getting when hands are not normal. It's dramatic. Advertisers know this. That's why hands are part of the big three advertising images, along with faces and sex. We use our hands to communicate profound emotional experiences. They are what make us human. They remind us who we are and how we feel. The symbolism is strong, as noted by Dr. Brand, who worked with lepers in India and pioneered our understanding of hand biomechanics. But how did we get here? A long road. Bottom left, that's a spider fossil. 380 million years ago, spiders had already evolved, 8 legs, making silk, doing their thing. We were not as far along. Our ancestors had settled on the pattern of 1 upper arm bone, 2 forearm bones. Another 30 million years to 5 rays in the hand. And after that was settled, it took 300 million years more for evolution to settle on the number of segments in each ray. Genetically, patterns like this are controlled by Hox genes, which are master control genes that determine the basic template, segmentation, number of extremities, that kind of thing. About 55 million years ago, our ancestors made 3 shifts. First, from nocturnal to daytime living, we came out into the light. And second, from solitary to social group living. And the third was that around this time, the paws changed to become more like hands with a new ability to grasp. Claws moved from the fingertip to the back of the fingers, flattened out and became fingernails, and this exposed sensitive fingertips. This was an abrupt shift, probably represented a Hox gene mutation. A single mutation can have cascading big effects. 30 million years later, there was another upgrade, opposable thumbs. Now, contrary to popular belief, humans don't have a monopoly on this. They've been around for a long time. A number of other primates have opposable thumbs. We're not special that way, but we are special, and here's why. It starts 6 million years ago with the extinct Auroran tugenensis, our oldest unique primate ancestor. The chimp is our closest living relative. Auroran had an upgrade compared to the chimp and all the other primates. Its fingertips. The tip of the end bone of our fingers has this kind of boomerang-shaped tuft on the palm side of the bone, a flat, wide arrowhead. A little further back from the tip is a recess which supports sensitive, fleshy tissue, and a little further back from that is a raised crest where the flexor tendon inserts. The size of the crest reflects the size and the strength of the flexor tendon which attaches there. Now these are the end bones, the distal phalanges, from different views, front, side, and oblique. Humans are in the right column, Auroran fossils are next to us. You can see the similarities. But if you look at the chimp and the gorilla, they don't have that wide, flat tuft at the end, which you need for a good, sensitive fingertip. And their tendon insertions are not as well defined, which means they're not as strong, not as useful. Now while we're here, an interesting point about fingernails. The rate of growth of fingernails is determined by how long that end bone is. So your middle fingernail will grow faster than your pinky fingernail, which has a shorter end bone, which will grow faster than your small toenail, which has an even shorter end bone. Now moving 2 million years beyond this, we can thank Lucy, our Australopithecus ancestor, for a number of additional upgrades. Lucy's extremities were abruptly different than her ancestors, and again, most likely from another Hox gene mutation. Her big toe moved in next to the other toes, and for the first time became weight-bearing. Now, chimps bear their weight on the outside of their feet. That's why they walk bow-legged. The toe shift is just part of a regional extremity change. The legs straightened, the pelvis changed, which allowed greater hip rotation, and all of this allowed Lucy to pivot her whole body, which allowed her to throw more effectively. It's a great advantage in hunting and fighting. A big upgrade. Now, around this time, the orientation of the shoulder socket, the glenoid fossa, changed from facing more up to facing more down. And Lucy's pinch changed in a fundamental way. Now, chimps can oppose the thumb to the side or to the tip of the index finger, but they don't have true pulp-to-pulp pinch, and this required changes in the skeleton. The proportions of the hand changed. It's hard to get a pulp-to-pulp pinch when the thumb is so much shorter than the index finger. And also, the chimp doesn't have the right muscles to do this. It required new muscles. Well, what ones? Well, here's our palm. Chimps have almost all of this stuff. Let's peel away the abductors, and then the short flexors, and then the opponents. Okay, let's just throw out everything except the things that we have that the chimp doesn't have or isn't that well developed. Now here's what's left. The dark blue is a stronger, bigger first palmar interosseous muscle. The light blue is the tendon of the flexor pollicis longus, which was much bigger and stronger, bends the end joint of the thumb. And in the brown is the deep head of the flexor pollicis brevis muscle, which was new in this model. What these amount to is these new muscles strengthen the adduction of the entire thumb ray. That is, they pull the entire thumb over toward the rest of the hand. And they rotate or supinate the index finger to allow the index pulp to face the thumb. Now, the index metacarpal head also changed in a way that allowed this rotation to occur. And this new index and middle ulnar deviation also allows a variety of three-point pinch positions. That was all great stuff, and thank you, Lucy. But it wasn't until about 2 million years ago that our genus, Homo, arrived with some pretty impressive accomplishments. First, regular use of fire, which led to cooking. Cooking increases the caloric content of food and provided more fuel to be able to power bigger brains. First, regular tool making. Now, a lot of other animals use tools, but they use found objects, sticks, pebbles. That's really different than manufacturing a tool. Now, Homo also had a big anatomic upgrade, which improved the ability to use tools and to use weapons. And this is the thing which makes our hands truly unique, something that neither our extinct ancestors nor any of our living primate relatives have. The ring and small fingers rotate down at the palm at the carpometacarpal joints. This is the thing which actually makes us human. The ring and the small metacarpals sit on the hamate bone. Now, in other primates, these joints have the shape of a hinge joint, but in Homo, it's a flattened saddle shape, like the joint at the base of the thumb, which lets the thumb swivel around. The upgrade was letting the pinky finger move a little bit like the thumb. Now, it doesn't seem like much, but it really is. First, it allows the back of the hand to shift from being flat to curved, which forms the transverse metacarpal arch. This converts a cylindrical grip into a stronger, more effective three-point grip. The small finger ray provides nearly a third of the grip strength and torque strength to the hand. Second, unlike a chimp, cylindrical objects can now be gripped at an angle. Tools can be used as a lengthwise extension of the arm, which makes them more effective as tools and much more effective as weapons. This also allows spherical grip, which along with the hip and shoulder changes further improves the ability to throw. This rotation is why in flexion, all of our fingers converge on the same spot in the proximal palm. That's the distal pole of the scaphoid bone. Evolution in 3 pinch postures: opposition, pulp pinch, and ulnar grasp. It's really amazing how smoothly the anatomy works for grip, which is the sum of many things. The flexor tendons in their sheath, extensors, the intrinsic muscles, the retinacular ligaments to hold everything in place, and when you draw a line connecting the axis of rotation of each of the joints, you get a Fibonacci spiral. The amazing thing is the simplicity at the base of what seems so complicated. And we haven't talked about the nerves, so we should. Now here again, there's a simple organization of what might seem complicated. A mnemonic for the function of the three main nerves to the hand is the radial nerve powers all of the extensor muscles. It opens up the hand ready to be used. Position. The median nerve supplies the muscles needed for fingertip pinch and also supplies fingertip sensation for precision. The ulnar nerve, controlling many more muscles, gives us a strong grip, and that's power. So position, precision, and power. Simple. All of this hand function requires a lot of brain power because the hand is actually just a big extension of the brain. Now you've seen the cartoon homunculus on the surface of the brain mapped out by the neurosurgeon Wilder Penfield. You learn from taking care of burn patients that the hands represent about 1% of the body's surface area, but in the brain they occupy about a quarter of the somatic cortex, sensory and motor. Coincidentally, a quarter of the bones in your body are in your hands. Now this guy with the big hands is really just an artist's representation. It looks more like this, and these are the areas of the brain involved, but the proportions are there. Red is fingers. That's a lot of real estate, and it's connected to even more real estate. Functional brain imaging shows that hand processing areas in the cortex light up with language tasks, as well as counting, ordering, enumeration tasks. They're wired together. On the other hand, accuracy of hand tasks relies on visual or auditory input for orientation. To this blindfolded subject, all of the dowels under her palm feel parallel to each other, because without sight she can't fully orient the direction of her hand. Now this is something which helps surgeons. Your ability to follow small changes in what you're looking at improves when your hands are actually in the same visual field. Simple question. How do we move our hands? Well, it turns out that in conscious movements, volitional control, there are two types of actions. There's slow motions, which are guided by continuous monitoring. That is, we're aware of our hands. We look at our hands as we do slow motions. With slow movements, the agonist and antagonist muscles fire simultaneously, like guy wires holding your hand in position. Now, ballistic motions, we're only aware of the starting and stopping points. We look at the target, not at our hand getting to it. Muscles in ballistic motions alternate between agonist and antagonist muscles. The key difference is that with stress and fatigue, slow motions become less precise and have increasing tremor. Ballistic movements are faster, more precise, and less affected by stress and fatigue, and that's because they're under unconscious control. Now, take-home point. When you first learn a manual skill, all of your movements are slow. That's why it's difficult. As you practice, portions of your slow motions are progressively replaced by ballistic equivalents. When you look at an experienced manual artist at work, most of their movements are ballistic. They're casual, fast, and accurate. The same is true in learning surgery, microsurgery in particular. That's why the learning curve to that point when you first start out, it's a struggle, and then suddenly things get easier, which means that you've finally gotten to the point where some critical percent of your motions have become ballistic. But we can precisely control only what we sense. Motion guides touch, and vice versa, and combining the two is what's called haptic information. Now, extended physiologic proprioception is the haptic mother lode. That's when, using a tool, your perceptual experience is transparently transferred to the end of the tool. You perceive the tool as you. It's what makes using surgical instruments feel natural when doing surgery. But how do we feel? Well, there are about 17,000 cutaneous mechanoreceptors innervating the palm of one hand. There are four types. There's superficial, Meissner, and Merkel, and they're deep, Pacini and Ruffini. So Meissner, Merkel, Pacini, Ruffini. Darker color round shapes are fast adapting, Meissner, Pacini. The lighter color irregular shapes are slow adapting, Merkel and Ruffini. And this is something which makes everybody's eyes glaze over, but what does this actually mean? So here's a way to understand it and also to remember for tests. The fast adapting receptors are sensitive to change and movement, and fast receptors have an S sound in their name, Meissner, Pacini. The slow adapting receptors sense static findings. Those are the Merkel, Ruffini. Superficial receptors tell us edge information with fine definition and start with the letter M, Meissner, Merkel. Deep receptors give information about pressure and shearing forces, Pacini, Ruffini. So now we have all bases covered. The palm has both superficial and deep, slow and fast receptors. A feeling in grip is no good if the skin is slippery, and the answer to this is sweat. Our palms sweat very precisely to provide tactile adhesion, and our palms sweat differently than the rest of our body. The anatomy of how our palms sweat is pretty cool. The sweat ducts surface only at the very top of the fingerprints, the papillary ridges. And these are the actual skin contact areas. That's where you need them. In the rest of the body, sweating is hardwired to temperature control. It's regulated by local temperature. The palm is different. The point of palm sweating is to improve your grip, to improve tactile adhesion. And there, sweating is a sympathetic nervous system response to local pressure and shearing forces. That's why if you're having trouble picking up a piece of paper, rub your fingertips together hard and you'll better be able to. Thanks, Pacini and Ruffini. So your fingerprints are lines, but each line has a series of holes running right down the middle. These reduce the surface area of contact, but the sweat that comes out of these holes more than makes up for it. I'm sure you've asked, why do wet fingers wrinkle? Well, the most current theory is that water is absorbed via the sweat ducts. Tap water is hypotonic. Electrolyte change triggers sympathetic mediated vasoconstriction, which shrinks the volume of the pulp, and the skin wrinkles like a prune. Now, someone who's cut the nerve to their finger or has autonomic nervous system dysfunction like in Parkinson's, their fingerprints won't wrinkle with tap water immersion. Now, you can prevent wrinkling by adding salt to the water. Palmar grip is enhanced by a hidden bit of anatomy, the palmar monticuli. These are the puffy areas in the palm in between your fingers. These pooch out and form contact areas during grip. Now you can see these when you bring your fingers together and cup your palm. They disappear when you spread your fingers. They're obvious in this baboon hand on the left where they have fingerprints. They look like fingertips. They're less obvious in humans unless they pooch out in between Dupuytren's cords, as on the bottom right, or when they're marked by red, as in the top right with palmar erythema. Counting or ordering appears to have a right-left orientation. There's a lot written on this. We tend to associate small with left, large on the right. It's controversial as to the learned effect reading has on this, and more complicated in that in some languages like Hebrew, words read right to left, but numerical ordering is left to right. Now, looking at someone else's hand, it's surprisingly easy to stumble or have trouble remembering whether it was a right or left hand you were looking at, particularly when the hand is turned 180 degrees from yours. Which brings us to handedness. Humans and other primates often use one hand more than the other for reasons unknown. So how do we define handedness? Is it the writing hand, the hand we use more, the hand which learns a new task faster or is just more coordinated? There are a handful of standardized tests developed to quantify the degree of handedness. Now, there's some degree of inheritance to handedness. It gets passed on, but it's not a very strong trend, and beyond that, it's really not well understood. It is known that handedness begins in the womb. Most fetuses move their right arm more than their left by 9 or 10 weeks, and fetuses tend to suck their dominant thumb in the womb. Now, left-handed and mixed-handed primates have a larger connection between the two hemispheres of the brain than right-handed primates. but it's not entirely in the brain. Otherwise, why would the presence or absence of the palmaris longus muscle in the forearm relate to handedness? And handedness changes with age. We become more ambidextrous over time, men more than women. Why men more than women? Well, they start out that way. On the average, men are about 1% more likely to be called left-handed than women. Men are more likely to be ambidextrous. Women tend to be more strongly right-handed or strongly left-handed compared to men. Now, there are many studies on the topic of sex and handedness. It's very interesting. Here's an analysis of over 1,400 people finding a slight relationship between handedness and sexual preference. Now, this may be true, but don't go blindly accepting the results of one study. The dirty little secret in the world of academic publishing is that papers reporting positive results or interesting results are more likely to be published than those showing no relationship. It's publication bias, and the truth on this topic is really still debatable. And there's still a lot of confusion regarding the basic definition of what is left-handed, right-handed, or mixed-handed. Handedness is a continuum. If you just ask which hand you write with, very few people answer both. But that's very misleading. Mixed-handedness is very common. On the right, a breakdown of 1,100 people using the Geschwin score of handedness. According to this, close to a third of the population is neither strongly right nor strongly left-handed. Most people who write with their left hand are actually mixed-handed. Most people who are mixed-handed are called right-handed. And being mixed-handed doesn't mean you do the same with both hands. It actually means you do some things with one hand and other things with the other hand, that you divide the labor. Now back to men and women in the same Geschwin study. Women in the red are more lateralized. They're less likely to be mixed-handed. They're more likely to be strongly right or left-handed. And, strictly speaking, looking at this, men are not more left-handed than women. Men are more mixed-handed, which winds up being called left-handed. Even more obvious when you break right into left into weak and strong. Women are more lateralized. Men are more mixed-handed. Lateralization is literally in the brain. At the top, a strongly right-handed person shows activity in the left hemisphere when they use their right hand, in the right hemisphere when they use their left. Below, a weakly left-handed person fires up both hemispheres to a greater degree when using either hand, less lateralized, requires a bigger corpus callosum joining the two hemispheres of the brain. Now on to urban legends. There's a common belief that artists and scientists are more often left-handed, but there's no big study to back this up. Urban legend is that Picasso, Einstein, Ben Franklin were left-handed, but pictures of them show them writing with their right hand. They may have been mixed-handed, but they're not obviously strongly left-handed. There are trends in handedness in different professions which don't show any clear trend. Sports is different. Half of top-level fencers are left-handed. Being left-handed gives some advantage in some sports, including Olympic wrestling. Being mixed-handed gives a slight advantage to learning a new language, and mixed-handed also better able to learn a new manual task with one hand after having learned it first with the other, like learning to play guitar and then trying to play it backwards. Michelangelo Badio, voted #1 guitar shredder of all time by Guitar One magazine, plays incredibly fast guitar, right-handed, left-handed, backwards, cross-handed, pretty impressive YouTubes. Clearly has some extra circuitry that didn't come with my model. There are some health issues relating to handedness as well. For reasons unknown, kids tend to break their left forearms more than their right, regardless of their handedness. Being left-handed is a risk factor for serious injuries using power tools, which are generally designed for right-handers. On a table saw, people tend to push items toward the blade with their dominant hand, placing at risk. But the opposite's true using a handheld saw. Now remember, women are more lateralized, less ambidextrous than men, and they also tend to fall more lateralized, tending to land on one hand more than on both hands, like their male counterparts. And this, for women, increases the risk of wrist fracture compared to men in a fall. Hand surgeons get asked a lot of strange questions, like this topic. The index ring length ratio has gotten a lot of attention in the last 15 years. In men, the index finger tends to be shorter than the ring finger. In women, the opposite. Now, it's there at birth. It doesn't change with puberty, and it's complicated. The growth and differentiation of the hand is controlled by the Hox gene system, which is regulated by a control protein called sonic hedgehog. I'm not making this up. Molecular biologists, pretty wild group. It's believed that this is somehow influenced by fetal testosterone, which is also one of the theories of the sex association of handedness. Beyond that, there's only wild speculation. And lots been written on this, provocative stuff, but also influenced by publication bias. As the literature accumulates, it's clear that the early reports relating this to sports ability, sexual preference, and a number of other issues have not been confirmed with more studies. Now, we talk with our hands, sometimes figuratively, sometimes literally. Gorillas, mandrills, other primates use some hand signals between themselves and can be taught hand signals to communicate with humans. Now, there are invented hand languages ranging from waiters' hand signals to American Sign Language. These work, but they're artificial, like Esperanto or Klingon. And then there are natural hand languages and gestures which are so pervasive in some cultures that at one time there was discussion as to whether talking with one's hands was inherited, and this was investigated. In the late 30s and early 40s of last century, there stemmed from Nazi Germany a trend to do scientific studies with racial overtones, as if to quantify differences between the races. And along these lines, David Efron did a study of two ethnic groups in New York City who had a reputation of talking with their hands. He did a meticulous study of nearly 3,000 people, with interviews, observational notes, 2,000 sketches by artists drawing people as they talked, 5,000 feet of film, and years of analysis of hand gesture type, style, context, rhythm, and other variables, and he developed a classification of gestures and came up with interesting results. Now, he looked at traditional, not Americanized, Eastern European Jews living in New York City. He looked at traditional Southern Italians living in New York City, and he looked at the Americanized descendants of these groups. He found that the Polish and Lithuanian group used hand gestures to demonstrate the train of thought of the speaker, the how of the storyteller's mental process, rather than the what of the actual content of the story. In contrast, the Italians were more literally talking with their hands. They're demonstrating objects and activities in the story and used over 150 specific gestures associated with specific words, some dating back to ancient Greece and Rome. Efron found that the Americanized versions of these groups didn't talk with their hands much, were much less consistent. So, conclusion, the entire phenomena is cultural, not genetic, not racial. You can talk with your hands or you can talk with your mouth. It's hard to talk when either are broken. There's a similarity in the way that they break. Now, jaw fractures often break in two places because the mandible is attached to the skull on both sides. It forms a closed loop, and like a pretzel, it's hard to break in just one place. Now, mechanically, the forearm bones also form a closed loop. You can break both forearm bones at the same level. That's pretty simple. More interesting are longitudinal forearm fracture dislocations, where the fractures at one level matched with a dislocation at another level. So, back to the Italians. Which of the eponyms of the three patterns of longitudinal fracture forearm dislocations have Italian eponyms? Answer, all of them. Number 1, proximal radius fracture and distal radial ulnar joint dislocation is the Essex-Lopresti injury. Number 2, ulnar shaft fracture and radiocapitellar dislocation. That's the Monteggia fracture dislocation. And number 3, radial shaft fracture and a distal radioulnar dislocation is the Galeazzi fracture dislocation. Italy, apparently a rough place for forearms. Now, speaking of eponyms, here are some common hand-related eponyms. Surgeons know all of these, but I know it's frequently a topic of conversation. Who were these people? There are several conditions named after Dupuytren. No surprise, he was a brilliant surgeon, a shameless self-promoter, and took credit for other people's work. Cooper had already published a description of the palmar contracture and surgery for it years before Dupuytren. It should be called Cooper syndrome, but Dupuytren got the eponym. Now, Dupuytren's contracture is sometimes associated with Pacinian corpuscle hyperplasia. The year Dupuytren died, 23-year-old medical student Pacini presented a paper to the Medical Society of Florence, Italy, humbly titled New Organ of Pacini. Now, he was another self-promoter, but the name stuck. He went on to a lifetime of microscopic work, but no new eponyms. Some of our eponyms have evolved. German military surgeon von Esmark designed a 4-foot wide triangular cloth sheet which could be folded different ways. It could be used to squeeze the blood out of an extremity, but more often was used as a bandage to hold on a splint. Esmark was a giant. He gave us a fundamental change, treating extremity gunshot wounds with local care rather than amputation as was done in the Civil War. But what surgeons call an Esmark bandage is really completely different than what Esmark actually invented. And speaking of bandages, tight bandages were the culprit for the ischemic forearm muscle contractures that Volkmann described in his short paper. This patient can straighten his wrist or his fingers, but not both. This eponym was a minor contribution for Volkmann, who was a great surgeon and a scholar and published widely not only in surgery and medicine, but also authored a series of very popular children's books. Swiss surgeon Decrevane described surgery for first compartment tendinitis his first year in practice, but his real interest as a general surgeon was goiter. Decrevane is the person responsible for putting iodine in table salt to prevent goiter. His name should be on that. And it shouldn't be on this. This tendinitis should really be called Kocher's tendinitis because Decrevane's 1895 paper clearly credits Swiss Professor Kocher of the Kocher clamp as the first to describe fibrous stenosed tenosynovitis. And that's okay. And speaking of Ks, K-wires are short for Kirschner wires. German general surgeon Kirschner was a student of Trendelenburg. He was the first surgeon to successfully perform pulmonary artery embolectomy, Trendelenburg's operation, and successful meaning that the patient survived. Now, Kirschner used thin wires for fracture traction. At first, he passed piano wires through drill holes in the bone and then put them under tension in a turnbuckle traction bow to make them more rigid. This technique was later adopted by Elizarov. Kirschner was a tinkerer. He developed an accordion-type wire stabilizer to let him drill long wires through the bone without bending. The short K wires that surgeons currently use came much later. I was really shocked to find this out. And speaking of shocks, Tinel was a 5th-generation French general surgeon with an interest in nerves. He was the first to describe paradoxical hypertension from pheochromocytoma. He invented the first intracranial pressure monitor. In World War II, Tinel and his family were put in prison by the Nazis for working with the French resistance and hiding downed American pilots. One of his sons died in prison. After Tinel's death, another of his sons followed his steps to become a 6th-generation French general surgeon. Now, you may have noticed that none of these hand eponyms were hand surgeons. Why? Because there was no such thing as a hand surgeon until recently. World War I. No organized approach to manage hand injuries, despite the fact that almost 1 out of 5 military injuries involved the hand. They were treated by whoever was available, usually the most junior staff. World War II rolled out, and hand casualties started rolling in. There were already established military triage and treatment protocols for abdominal injuries, neurosurgical injuries, and others, but nothing formally organized for hand injuries. Surgeon General Norman Kirk changed this. He tapped his friend Sterling Bennell, who was a general surgeon who'd published articles on hand injuries. Now, Bennell was 62, too old to serve, so Kirk got Bennell to close his practice and appointed him special civilian consultant for hand surgery. 9 hand centers were established in the U.S. base hospitals during the war, and Bennell spent 2 years traveling back and forth between these to operate and teach at each, like a reverse hand fellowship for the guys at the hospitals, who then became the first generation of hand surgeons. They were very busy. 22,000 injured hands from that war. After the war, these surgeons taught the next generation of hand surgeons, who were my mentors. I am a 3rd-generation hand surgeon. Hand surgery is awesome. It's a little bit of everything. It's a child of many parents with a finger in many pots. And it's a common concern. Hands are on the front line for injuries, tendinitis, arthritis, neuritis. There's a huge need for hand surgeons. In hand surgery, you can be a generalist or you can be a super specialist. I started out in academics. I was a hand and micro hand guy. Then I moved on to private practice. I took care of a lot of congenital hand. I started in private practice in orthopedic group, but then moved on to solo practice. I got work comp contracts and became the work comp guy, which was about 80% of my practice for years. I then moved on to new joint implants to be the arthritis guy, but the new rheumatoid drugs really dropped the number of rheumatoid patients. I then got involved with needle aponeurotomy, and Dupuytren's has been 90% of my practice for the last 8 years. I've always been 100% hand, covering everything up to and including the elbow. So there's a huge amount of variety of what you can do, and you can change around within your own practice. We started with the evolution of the hand. We've seen the birth of hand surgery. Now I'm going to show a few things which evolved in the 25 years since I was a hand fellow. Like any evolution, it's not a straight line. It's a spiral. And putting things in context, I made this cutting-edge title slide as a resident. I drew it on my Commodore 64, printed it on my dot matrix printer, took a picture with a yellow filter on the lens of my 35mm film camera, then used the negative film in a slide mount to reverse colorize the original black on white to become white on blue. Orange cellophane rectangle over the middle to get that different shade of blue. Boom! Probably spent 15 hours on it, including 2 trips to the camera store to get it developed. Things have changed, fortunately. I got to watch the birth and decline of repetitive strain injury, which is the demon offspring of pseudoscience, irresponsible journalism, and legal work comp profiteering. There is no strong evidence linking sedentary computer work to any upper extremity disorders. P.S. There's no such thing as BlackBerry thumb or iPhone finger. Now this is different from high force, high repetition, heavy manual labor, or chronic exposure to vibration from handheld tools. The bottom line is problems tagged as repetitive strain from office work created a pseudo-epidemic a few years ago, and they're common in the general population, working or not. We still don't know on a cellular molecular biology level what actually causes carpal tunnel syndrome, tendinitis, osteoarthritis. There's a world of opportunity out there to investigate these conditions. Whatever is the cause of tendinitis, it's not just overuse, which is a pseudoscientific catchphrase, not an explanation. You should avoid it. Multiple sites of tendinitis are common, which makes you wonder whether tendinitis is a local event or the canary in the coal mine. For example, tendons respond to mechanical stress with TGF-beta mediated collagen molecular remodeling, and it's reasonable to speculate that in some cases of tendinitis might be a local manifestation of a systemic dysregulation of this biology, like Dupuytren's. This is a hot topic for more investigation. I got to watch the evolution of treatment of distal radius fractures. In training, I learned pins and plaster. Pins in the bone on each side of the fracture left sticking through the skin, incorporated into the cast to provide traction. A weird looking cast with bumps over the pins. I like the way this patient decorated theirs. Fun, but very unforgiving. You get only one shot. This is do-it-yourself external fixation. Pins and plaster were good at maintaining length, but not at intra-articular fracture alignment. We had the Synthes plates and screws, which were okay to use as buttress plates, but weren't good at maintaining length. They were mainly used when pins and plaster failed, as in this case. A variety of X-Fix products were developed, as well as do-it-yourself versions like this pin, methyl methacrylate, and ventilator tubing on the bottom left. 2 common problems. Proximally, with pronation and supination, the radius rotates more than the skin. The pin sites get irritated. Distally, the superficial radial nerve can get dinged. Here, I'm burying a superficial radial nerve neuroma in bone from someone else's X-Fix. An improvement on the external fixation approach was using plate and screws tunneled beneath the skin, like a buried external fixator, to maintain length and restore the dorsal contour. It's much better tolerated. I put in a bunch of these. The game changer was the concept of fracture-specific hardware. The Med-Off TriMed system had little bits of hardware for different areas of the distal radius. It looked like a junior erector set, but for the very first time you actually could put Humpty Dumpty back together again. A lot of work, but very cool. The next upgrade, locking fracture-specific plates. The best features of plates and external fixation, maintaining length and controlling the articular fragments strong enough to allow immediate motion. This is my current favorite. There are now many versions of this concept. Evolution of fracture-specific hardware made a big difference for these fractures. Story number 2, scaphoid non-unions. What a dog. They just won't heal. The big tool when I was training, corticocancellous bone graft, pressure fit into a window made in the scaphoid non-union site. Significant failure rate. Tried to avoid this. As a resident, I saw patients with scaphoid non-unions who had been in an above elbow cast for a year and a half and then needed surgery, which sometimes didn't work. We had hardware, just not the right kind for this bone. On the left, this dentist had a screw for scaphoid fracture 35 years ago, still not healed, probably why the screw has migrated out. You can't get good compression in the scaphoid with a regular cortical screw. The scaphoid's basically all joint surface. There really isn't a good place to leave a screw head poking out. And that's why the Herbert headless compression screw was such a game changer. It was developed for scaphoid non-unions. And finally, we could get predictable enough fixation to do a bold resection of the non-union site and bone graft a long-standing scaphoid non-union with predictable healing. As experience grew, this screw proved useful for difficult acute fractures like this proximal pole fracture and could be placed with minimal exposure, even percutaneously. The dream team for difficult non-unions was the development of vascularized bone graft and solid fixation, like this vascularized pedicled 1-2 intercompartmental septum dorsal radius graft for a very proximal pole scaphoid non-union. It's an amazing concept put into reality. Now, moving from fractures to arthritis. A third of women and a quarter of men over 65 have X-ray evidence of basal joint arthritis. Why? A mystery. Why are this patient's metacarpophalangeal joints pristine and his basal joint a complete wreck? A mystery. Fortunately, less than a third of arthritic basal joints hurt. And why is that? A mystery. This patient has no thumb pain and never has. For those that do hurt, the original operation for this was trapeziectomy followed by immediate motion. Some patients had problems with subsidence. The entire thumb ray moved proximally. This problem was attacked by the development of implant arthroplasties. When I was a resident, silicone basal joint implant arthroplasty was well established. Fun operation, worked pretty well, except that those had a tendency to dislocate, and if they didn't, they had a tendency to wear down, and the particulate debris caused silicone synovitis. Now you can see the cystic changes from this throughout the carpus. The implant's still in place, although the thumb's dislocated. I saw this patient not for the thumb, but for the ulnar nerve irritation and a painful ulnar wrist mass from this involving the pisiform all the way on the other side of the wrist, which I removed. That's the ulnar nerve there. The path showed granuloma with silicone fragments, classic finding. Now this was no good, so other methods were developed with two key concepts. One principle was ligament reconstruction to hold the thumb out to length so it wouldn't subside. People tried all kinds of things. It was the Wild West. Here's a case I observed as a resident. A slip of the abductor was harvested, split in half, part passed through a drill hole in the thumb metacarpal base, part passed deep to the flexor carpi radialis, woven back and forth, 17 more steps. You can make things as complicated as you want. Second principle was filling the hole after taking out the trapezium. Here, simple tendon interposition, balled up flexor carpi radialis dunked into the trapeziectomy defect. Now the common thing is to combine the two, ligament reconstruction, tendon interposition, LRTI. Basal joints are a common problem, and the best treatment was not known, and that's the definition of a perfect opportunity. I took it as a personal challenge, developed my own instruments to simplify the steps of trapeziectomy, tendon harvest, tendon weave. This isn't uncommon. All surgical instruments were invented by somebody. Most hand surgery instruments have been stolen from other specialties, and often they don't quite fit, so there's always room for improvement. It's wide open for you to roll your own. It makes hand surgery fun. I tried all different sorts of attacks on the basal joint, weaving the tendon around the index metacarpal for better placement, arthroscopic debridement, pinning the joint without any other reconstruction, other soft implant materials like rolled up Gore-Tex graft, PS don't do it, carbon implant, absorbable suture suspension arthroplasty, and others have tried all sorts of other things. And as the evidence is rolled in, recent review, best evidence is that the best improvement on the original basal joint operation, trapeziectomy and immediate motion, is trapeziectomy and immobilization for a month. Fewer complications than any other procedure, and no other procedure has a proven advantage on any other metric. So that's what I'm currently doing. The spiral of progress continues, but there is work yet to do, and the drumbeat is evidence-based medicine. Most of what we do is based more on cumulative personal experience than rigid analysis. We still lack hard evidence on the best treatment for many common conditions. There is more work to be done to make a difference in what remains an amazing field. And there is so much more waiting right within our reach. Thanks for listening.